Okay, thank you very much. So I try in this presentation to talk more about the LithiX 2 millimeters. That is a very dedicated device because is for the first time the first IVL that have this kind of diameter. But why we need the small IVL balloon? I think that we can need these tools in this specific setting like tortuosities, branches, or just for regular standard PCI distal lesion, or in case of instability to avoid atherectomy. We know that atherectomy is a very good tool. We also know that atherectomy is burdened by hard complication. Here you can review just some of that probably all operator experience in his life. So what's the best approach if you have to use a 2 millimeter balloon? We try to reply to this question. And just to summarize, I think that a stepwise approach dedicated to this size is needed. Basically, the clinical scenario that I have already summarized is that one. And we have to use 2 millimeters different from other cases that we reviewed today to create some initial space. And then we have to follow with NC or maybe with other debulking device to get the final result. So in our experience, the first step is that we try to cross with a small balloon, probably 1.5 could be a good average size to confirm that lesion is uncrossable. Is nearly crossable by a small device. I mean, if you cannot cross with such smaller balloon, you can try to increase support. I mean, with a larger size of guiding catheter, with child mother, with a smaller balloon, or you can consider directly to switch to atherectomy in such uncrossable lesion or near uncrossable. If you would like to try to deliver the 2 millimeter LithiX balloon that I will stress that is 2 millimeter 14 as a length, I think that is good to confirm that you can cross with at least a 2.8 millimeter non-compliant balloon to be sure to have enough deliverability. If you fail, you can again increase the support and attempt again, as is you have a good chance to cross with this technology in our experience. Then you will use the LithiX as we already discussed, starting with a low atmosphere and increasing the atmosphere as needed. And then you have to optimize, and in that case, probably you need to work more in optimization to get the final lumen. So to go more in deep in the cases, in this section, I will talk about tortuosities branches. I mean that this is the case of 75 years old with some risk factor. We already performed an LID PCI a few months previous of this procedure, and we have in this procedure to work on this marginal branch. As you can see, there is some kind of tortuosity in the proximal circuit, and we finally need a dedicated super cross angulated catheter to cross this calcified ostium of marginal. And then we try to use this way to work with this flowchart. As you can see, the semi-compliant 1.5 fails to expand in multiple occasions. This is the same balloon in another position. So we decide to move it to the 2 millimeter. As you can see, in that cases, we have 3 ruptures of the balloon, 2 millimeter balloon. We can cross, but the region the balloon was unable to prepare and delay the lesion. So at this moment, we decide that we have this result. We have no slow flow, fortunately, unluckily. And so we decide that it's good to test LithiX. So this is the live performance of the deliverability of this balloon. As you can see, working a bit with the balloon, you can cross that lesion even if it's angulated. This is a 2 millimeter 14 balloon. And then we start 6 millimeters, 8 millimeters. We have to work 15, 20 seconds. And finally, we get this result at 12 atmosphere. As you can see, there is finally good expansion without no ruptures at all of the balloon. So moving over, we have to optimize with the NC 2.5 balloon, at least, because we have to get the sizing of this marginal branch. We are quite happy about this optimization. And at this stage, we perform imaging. As you can see by IVUS, there is a plaque modification, there is fractures of the calcium. We try to understand if the lumen is enough, and we decide, given to the ostial position of the marginal, in this specific case, to deliver a DCB with sirolimus 2.513, and we get this immediate final result. We have the opportunity to have an angiographic follow-up 3 months later, because the patient have to perform a DCB PCI also on PDA, and this is the result that I think it's very good for such patients.